Hi, welcome to today's in-depth medical review. In this episode, we're focusing on a cornerstone of internal medicine and nephrology, renal function tests. We'll explore what they are, why they matter, how to interpret them, and how they fit into the broader context of diagnosing kidney disease. Let's get started. Renal function tests are a group of essential laboratory investigations used to evaluate how well the kidneys are working. These tests tell us how efficiently the kidneys are filtering waste from the blood, maintaining electrolyte and fluid balance, regulating acid-base levels, and even participating in hormone control. Why is this important? Because through these tests we can detect and monitor acute kidney injury, chronic kidney disease, glomerular or tubular disorders, and systemic illnesses that secondarily affect the kidneys, such as diabetes or lupus. Let's break these tests down. 1. Serum creatinine. First up, serum creatinine. Creatinine is a waste product of muscle metabolism, specifically from creatine phosphate, and it's produced at a relatively constant rate. The kidneys filter it almost entirely through the glomerulus, and under normal conditions, very little is reabsorbed. For normal ranges, in adult men, it's about 7 to 1.3 milligrams per deciliter. In adult women, 0.6 to 1.1 milligram. When levels are elevated, it typically means reduced kidney filtration. But here's the catch. Serum creatinine can be influenced by muscle mass, age, diet, medications like cimetidine or trimethoprim, and even hydration status. So it's not perfect. In fact, you might not see a rise in creatinine until about 50% of kidney function is already lost. 2. Blood urea nitrogen, or BUN. Next, we have BN, or blood urea nitrogen. Urea is formed in the liver as a waste product from protein metabolism. It's filtered by the glomerulus and partially reabsorbed in the tubules. The normal range is typically 7 to 20 milligrams per deciliter. Elevated BUN can suggest dehydration, a high-protein diet, upper GI bleeding, or catabolic states like fever or sepsis, but it can also point to reduced renal perfusion, a sign of prerenal azotemia. Conversely, low BUN might indicate liver failure, malnutrition, or fluid overload. 3. The BUN to creatinine ratio. This ratio helps us narrow down the type of kidney problem we're dealing with. If the ratio is greater than 20 to 1, think prerenal azotemia. If it's around 10 to 15 to 1, that may indicate intrinsic renal disease. A higher or fluctuating ratio may also occur with postrenal obstruction. 4. Estimated glomerular filtration rate, or eGFR. Now let's talk about eGFR, one of the most important indicators of kidney function. This estimate is calculated using serum creatinine along with age, sex, and formerly race. Equations like CKDE are currently the gold standard. A normal eGFR is greater than 90 milliliters per minute per 1.73 square meters. Here's how we interpret eGFR. 60 to 89, mild reduction. 30 to 59, moderate reduction. 15 to severe reduction. Below 15, kidney failure. This classification also helps us stage chronic kidney disease. 5. Creatinine clearance. Creatinine clearance reflects how much creatinine the kidneys can clear in a minute. It's typically measured with a 24-hour urine collection or estimated with the Cockcroft-Gault formula. This test is particularly useful for adjusting medication doses, especially in hospitalized patients or those on nephrotoxic drugs. But it has its drawbacks. Urine collections are error-prone, and creatinine clearance can overestimate actual kidney function due to some creatinine being secreted by the tubules. Urinalysis. Urinalysis gives us a snapshot of the urine's composition. Macroscopic elements include color and clarity. The dipstick looks for protein, blood, pH, specific gravity, nitrites, leukocyte esterase, glucose, and ketones. Under the microscope, we can identify RBCs, WBCs, Cas crystals, and epithelial cells. Proteinuria and hematuria are especially helpful in flagging glomerular disease. 7. Urine albumin-to-creatinine ratio. This spot test is easier than a full 24-hour urine collection and is crucial for identifying early diabetic nephropathy and evaluating hypertensive end organ damage. Normal is under 30 milligrams per gram. Microalbuminuria ranges from 30 to 300. Anything above 300 is considered macroalbuminuria. Persistent elevation points to progressive kidney injury. 8. Electrolytes and acid-base tests. Kidneys help regulate potassium. Watch for hyperkalemia and CKD. Sodium hyponatremia may indicate fluid overload. Bicarbonate, metabolic acidosis can emerge in advanced kidney failure. Use the anion gap to help detect uremic acidosis. Nitin C. Cystatin C is a small protein produced by all nucleated cells and freely filtered by the kidneys. Unlike creatinine, it isn't affected by muscle mass or diet, making it a helpful tool for estimating GFR, especially in elderly, children, patients with low muscle mass or malnutrition. It's an emerging favorite for more accurate kidney assessment. There are also additional tests for specific pathologies. We can also use urine electrolytes to help differentiate types of kidney injury. A fractional excretion of sodium under 1% suggests prerenal AKI. Over 2%, likely intrinsic renal damage, such as acute tubular necrosis. Urine osmolality helps assess concentrating ability. Urine sodium levels give us insight into volume status and tubular function. Last but not least, let us not forget imaging. Though not lab-based, imaging complements biochemical testing. Ultrasound helps us assess size, structure, and obstruction. CT or MRI can detect tumors, stones, or vascular issues. Doppler studies assess blood flow and are useful in suspected renal artery stenosis. Also, there are clinical patterns that you should know. And let's look at some classic diagnostic patterns. Likely diagnosis: elevated BUN and CAR, low prerenal AKI, elevated BR, normal VAR, high Phe intrinsic AKI, isolated proteinuria, early diabetic nephropathy, hematuria RBC CAS plus protein glomerulonephritis, Peoria B CAS, interstitial nephritis, anemia, low eGFR, acidosis, chronic kidney disease, normal CR, elevated early kidney injury. In summary, renal function tests are vital tools that require thoughtful interpretation. No single lab tells the full story, but by combining creatinine, eGFR, BUN urinalysis, and albuminuria with clinical context and imaging, we can diagnose, stage, and monitor a wide variety of kidney conditions. Thanks for joining us for this comprehensive breakdown of renal function testing. Stay curious, stay clinical, and we'll see you next time.